Hey, Med Decode. Welcome to Med Decode. Today, we are diving deep into trauma. And I mean really deep. We're looking at it not just, as a painful memory or some kind of mental state, but actually as a physical molecular memory, something literally etched into the wiring of your brain.
Yeah, our sources today are talking about some pretty radical new possibilities, ways to potentially rapidly erase the emotional fallout from traumatic events. We're going to unpack the science behind two really powerful techniques. The well-known EMDR, that's eye movement desensitization and reprocessing, and also a newer, pretty fascinating theory called havening techniques.
And this is really high-stakes stuff we're talking about, because this deep dive, it goes way beyond just managing PTSD. What's truly fascinating here is the physical footprint of trauma. Trauma, especially things like adverse childhood experiences, ACEs, they aren't just mental scars. They're actually major risk factors for some serious adult physical illnesses. Right. Things like liver disease, coronary artery disease, autoimmune problems. I mean, whole range of chronic health issues.
Yeah.
There was one statistic from the research that it really stopped me. Individuals with ACE scores higher than 6.
Yeah.
Their life expectancy could be shortened by, get this, 2 decades.
Yeah.
A staggering number. That's the gravity of it. So our mission today is to really understand the potential solutions here. We'll decode the elegant science, some of it still speculative, mind you, behind how the brain creates this permanent alarm circuit and then how these new therapies claim to erase it. But critically, we also need to examine the controversies, the safety questions, and the serious risk of memory distortion with these powerful tools.
Okay, let's get into that. So if trauma is so damaging, why does the brain even bother storing it so permanently? It almost feels like, a massive design flaw. Well, it's not really a flaw, it's more of a feature. An ancient one. It's like a built-in immune system for threats. The issue is really its speed. See, your conscious brain, the part listening right now, thinking things through, it handles information at maybe, 10 bits per second? It's slow, deliberate.
Right, the speed gap you mentioned.
Exactly. But your limbic system, your survival brain, specifically the right amygdala, that's your threat scanner, it processes information subconsciously at billions of bits per second. It has to, for survival.
So the fight or flight thing kicks in before I even consciously realize I'm in danger.
Precisely. We're talking within 75 milliseconds. That's 4 times faster than conscious thought. If you were suddenly attacked, say, the amygdala needs to instantly link the sensory input, a sound, a dark street, whatever, to the danger response and lock it down for next time.
Okay, so how does the brain make that lock permanent? This is where the molecular science gets pretty detailed but really interesting. Let's talk about that initial encoding.
Right. So when you're under high stress and you also have this fast brain activity called gamma waves, the brain uses a key neurotransmitter, glutamate. This glutamate floods the synapse, the connection point, in the amygdala. It activates specific receptors, the NMDA receptors, and that causes calcium ions to rush into the cell.
Okay, but is that still temporary at this point? Like just a quick alert?
Yes, initially. But that calcium flooding in, that's the turning point. It triggers protein mechanisms that physically pull these communication channels, they're called AMPA receptors, onto the receiving end of the synapse. This upregulates the synapse, makes it hypersensitive to that specific trigger. The connection gets stronger.
But not permanent just yet. What's the sort of chemical save button?
That seems to be an enzyme called PKM-zeta. This is where it gets really interesting. Once those AMPA receptors are pulled in, PKM-zeta comes along and essentially puts a chemical lock on them. It phosphorylates them.
Phosphorylates, like cementing it in place.
Exactly like that. Think of it as chemically cementing that receptor right into the cell membrane. It permanently anchors that alarm circuit.
Wow. So it's like sinking a concrete block to hold down a buoy? And years later, even if the danger is gone, the original trigger, the smell, the sight hits that cemented synapse and boom, full-blown panic attack. Totally subconscious.
That's the theory behind chronic trauma's mechanism. The sources also had this useful mnemonic, EMLI, for what conditions really turn a bad event into encoded trauma.
Right. EMLI, event, meaning landscape of the mind, and inescapability.
And that last one, inescapability, seems psychologically crucial. Did the person feel totally powerless? Trapped. They give this example of a guy navigating a huge Arctic storm, clearly dangerous, right? But he was trained. He felt in control. He managed the threat. So it didn't encode as trauma for him. It's not just the event severity. It's that subjective feeling of being trapped and helpless when that alarm goes off.
Okay, so if trauma is this permanent PKM-zeta anchored circuit, how in the world do we switch it off without, deleting the whole memory? This is where that novel theory from Ronald Rudin comes in, the havening techniques idea.
Rudin's theory is fascinating. It suggests the brain actually has an innate molecular delete switch, one specifically designed to reverse that PKM-zeta anchor. And the key component, maybe surprisingly, seems to be delta brain waves.
Delta waves. Aren't those the ones from really deep sleep, like slow wave sleep when you're totally out?
Exactly, very low frequency waves. And we know deep sleep is heavily involved in memory processing. So the theory goes, if you activate the specific traumatic network by recalling the memory and at the same time flood the brain with these delta waves, you activate a counterenzyme, calcineurin.
Wait, is that like the molecular opposite of PKM-zeta?
Precisely. PKM-zeta adds the phosphate lock. Calcineurin is a phosphatase. It removes it. It chemically breaks that anchor. And this forces the removal of those extra hypersensitive AMPA receptors from the synapse. They get pulled back into the cell. So the emotional charge, the fear, the panic gets deleted. But the factual memory, that stays. You remember what happened, but it doesn't trigger the alarm anymore.
That's essentially a targeted molecular reset button. Okay, but here's where I get a bit skeptical. How do you flood the brain with delta waves when someone's wide awake remembering something awful?
This is the really intuitive leap behind havening techniques. It's the proposed link between soothing touch and generating delta waves. Rudin's work suggests that stimulating specific areas, the upper arms, the face, the palms of the hands, actually generates high levels of these delta waves, specifically in that crucial 0.5 to 2 hertz range.
That actually makes immediate sense, doesn't it? Intuitively. It's how we calm ourselves down, rubbing your shoulder, or how a parent soothes a child. It feels safe.
Exactly. It induces that feeling of safety. And the clinical results, at least anecdotally, are pretty astounding sometimes. You see these case histories, like a client who reportedly erased a 20-year trauma from an armed holdup in maybe 15 minutes.
Or that anesthetist example you brought up earlier.
Oh, yeah, the one with the needle phobia. Tell us a bit more, because that links the emotion directly to a physical reaction.
Right. So this patient was obese, severe needle phobia. And the fear caused intense vasoconstriction. Their blood vessels literally clamped down, made it impossible to get an IV line in. It was a physical stress response. So the anesthetist tried about 10 minutes of havening, and the patient apparently relaxed so completely that the veins became, quote, easily visible. She accepted the IV with no distress. It suggests the physiological alarm circuit was switched off almost instantly, leading to a real physical change. That potential is just literally rewriting a physical fear response, maybe even impacting chronic illness down the line. But, okay, whenever something seems this powerful, this fast, the ethical red flags have to go up. Let's shift gears now to that critical piece, the safety data, and this risk of memory distortion.
Absolutely essential we talk about this, because looking bigger picture, EMDR is already a first-line PTSD treatment, and it's being used more broadly now, anxiety, chronic pain, even addiction. But the safety profile, it remains, well, pretty shockingly under-examined.
Yeah, the data you found on that was stark. You looked at a recent review, 2026, right, covering 51 high-quality trials of EMDR for PTSD. And the basic question was, did they track bad side effects?
That's right. Out of 51 high-quality studies, only 9 even mentioned adverse effects, AEs. Just mentioned them. And out of those 9, only 1 actually used systematic ways to assess them, proper protocols.
Wait. Hold on. So 50 out of 51 top-tier research trials weren't actively tracking, in a structured way, if the therapy was causing new problems or making things worse.
That appears to be the critical gap. It leaves this huge vacuum when you're trying to figure out the real risk-benefit balance for doctors and patients. And that brings us smack into the biggest controversy. This risk of creating false memories. The fear that therapy might somehow implant a memory of a trauma that never actually happened.
Okay, so we need to be careful here. Separate the technique itself from maybe how it's used, right? Do the eye movements themselves make you more suggestible?
The research seems pretty clear on that, actually. The eye movements themselves, which seem to reduce the memory's vividness and emotional punch, they do not appear to make people more susceptible to suggestion-induced false memories. So the technique itself doesn't seem inherently dangerous in that specific way.
Okay. But the sources mentioned it might increase spontaneous false memories, like mixing up details, not creating whole new stories.
Yes, there's some suggestion of a potential increase in spontaneous errors, like confusing details. But if the technique itself isn't the main driver of invented trauma memories, what is the real danger zone?
Where's the risk come from, then?
It seems to lie heavily with the therapist's belief system, particularly around this really controversial idea of unconscious repressed memory. Surveys show that a very high percentage of EMDR practitioners. I mean, up to 80 or 90% in some surveys believe that traumatic memories can be completely blocked out and then recovered years later in therapy.
Oh. And if a therapist strongly believes those hidden memories are in there, they might push too hard to find them.
Exactly. That core belief, even if the therapist means well, can lead them to stray from standard protocols. They might start using suggestive techniques, consciously or unconsciously, to dig for these supposed hidden memories. And that practice is what seems linked to these therapy-induced recovered memories that might actually be false.
And there's evidence linking this consequence to the therapy context, right? The Dutch legal reviews.
Yes, that was a significant finding. In Dutch legal reviews looking into dubious abuse allegations where therapy-induced recovered memories were suspected, half of those cases had involved EMDR being used. It strongly suggests the primary risk isn't the eye movement itself, but potentially the suggestive framework or belief system that sometimes gets overlaid onto the treatment by the practitioner.
Right. So it's a really complex picture.
It really is. On one hand, we have these compelling, novel theories. We have astonishing case studies pointing towards potentially rapid trauma erasure with applications maybe far beyond PTSD into physical health, burnout.
But on the other hand, there's this significant ethical and frankly methodological hurdle. We absolutely need much more rigorous safety monitoring in the research and a much deeper professional awareness among therapists about the dangers of suggestive practices when you're dealing with something as delicate as human memory. So here's the final takeaway for you, the listener, from this deep dive. EMDR and potentially havening look like genuinely powerful tools. They offer incredible potential. But if you're considering them, please ensure your practitioner is rigorously certified. And maybe most importantly, check that their focus is squarely on processing the distress you know you have right now, not on trying to somehow uncover supposed hidden memories.
Yeah. And maybe the provocative thought to leave you with is this. What does it really mean? The fact that something as simple as gentle, soothing touch, the very feeling of safety and connection, could potentially trigger deep brain processes like delta waves and molecularly erase trauma encoding. Could the key to healing trauma lie less in directly confronting the terror and more in maximizing our feelings of profound safety and connection first? That really opens up a huge and I think exciting new way to think about how we heal.
And that's a wrap on this episode of MedDecode. I really appreciate you joining me today. If something we talked about sparked your interest, or if there's a medical term that's been bugging you, let me know in the comments. And if you enjoyed this, be a pal and share it with a friend. We'll catch you on the next one.